what's going to happen with your cravings and withdrawals over the next 24 hours. Hey everybody, welcome back to the channel, and today's topic is going to be framed as how to start Suboxone and medication assisted treatment or medication assisted treatment so that you may have the greatest chance of success in your endeavor. If you're new to the channel, my name is Dr. B. This is Dr. B Addiction Recovery. On this channel we cover all things substance abuse for all parties involved. I want to thank everybody and encourage those of you that are new. I want to thank everybody that contributes to our Patreon account, those that contribute to our channel membership account, all of the members, those that subscribe. And if you are new, if you like our content, please go ahead and please go ahead and subscribe. And we have a very reasonable Patreon account set up. So let's get started. And I am taking a little break from my methamphetamine series. I'm in sort of a purgatory going on, and I've had all kinds of stuff going on at the last couple of months. But we can frame the question, or it's been posed, how do I, what dose, it's often framed in so many different ways, and we sort of put it all together because the question comes at me, what dose of Suboxone should I start at? How long should I be on it? Does the naloxone do this? Does the naloxone do that? A lot of these questions I have gone into very detailed explanations in other videos, but here, if you are familiar with the issues, it should all come together. And it will be framed as, how can I start medication-assisted treatment or Suboxone so that I may be successful at quitting opiates? The first thing I want to point out is, why do we even have this question? And the answer is clear and simple, and it's been discussed in many other videos or discussions, because of the stigma surrounding both heroin abuse, substance abuse, opiate abuse, the addict. So that's number one. And it seems like anything that is attached with substance abuse, in this case the treatment of it, and if it brings up, in this case, opiates, you know, the treatment of it is buprenorphine products, which are a type of opiate, and it's going to have that same stigma. Okay, in that sort of framework is the 12-step phenomena, absolutely clean phenomena, and really we need a major paradigm shift. And these hang-ups that are out there create a lot of misinformation, disinformation, a lot of well-intentioned people and not so well-intentioned, that really create an atmosphere of a lot of information, very little knowledge. That's why this question exists, okay? And so let's get started. The first question, and I took a few notes here just before we started, the first question that I want to answer when you go to somebody to get started on medication-assisted treatment or Suboxone, first question people often have, or the thought they have, or the idea that they have is, I want to be on the lowest dose possible. And I want you to really shift your thinking when you approach this medication and what your plan is. I want you to, number one, find a competent physician that is going to spend time not just explaining this material to you, but giving you professional clinical support, empathy. Hopefully they are trauma informed and understand the importance of patient-centered care with disease that has so much controversy and sensitivity surrounding it that affect the patient, their thinking, their worldview. So you have to go to a clinician in that way. Two, hopefully the clinician explains this to you, but you should not approach with the idea of, I want to be on the lowest dose possible, or what is the right dose, okay? That's gonna set you up for failure, okay? And if the physician encourages that, that's gonna set you up for your failure. In fact, you shouldn't think about anything, okay? You should have your questions answered, and you should be educated, formally educated on this issue. The dose that you should start on is the dose that takes away all cravings in 24-hour period and takes away all withdrawal symptoms. If you don't you are potentially already, before even being out the gate, you're setting yourself up for failure. Okay? The patient, when they go to the clinician, they should have all of their questions answered in a very meaningful and honest way. What we do know, what we don't know, the side effects, the possibilities of long-term need for this medication. But you should go there with the idea that the dose I need to be on, and the clinician should understand this, the dose that needs to be titrated up to is the dose that takes away cravings and withdrawal in a 24-hour period, okay? And I'm going to avoid going into details of how some of this should be done because I already have it elsewhere, okay? And for you, that goal, really what it means is to be functional after I am started on this medication and at the appropriate dose, okay? To the extent that where I am dysfunctional is secondary to the fact that I have an opiate addiction or heroin addiction. That's number one, okay? Or rather, that's the first two. And, you should be expecting, I wrote here to remind myself, just to let you know, 16 to 24 milligrams, okay? It's not a big dose, that is what it is. And all of this is backed up by data at the international level. Okay. The third question that's on people's minds, and the clinician should really be savvy and sensitive to this issue, is how is this dose started? Do you just hand me, I go in, do I just get 24 milligrams, let's say, of Bonavale, Suboxone, whatever, Subitex, and I go home and get started? And today we're only talking about the oral formulations, okay? Usually they're sublingual or buccal. How should my dose in milligrams, the 24 milligrams, be started, okay? And what are the different formulations, okay? And when should I start this medication? I'm assuming some familiarity with this topic, as most of you know what precipitated withdrawals are. If not, you can refer to some of my other videos. And this should be your third question, and the clinician should be savvy about this. Let's start off with which brand. Let me just separate the two brands, the two types, okay? One of them is without the naloxone, and one of them is with. For example, Subitex is a pill and it's just pure buprenorphine. Suboxone comes in a strip form and it has a certain amount of naloxone in it. And as you all know, that's an opiate reverse agent, okay? Now, in other videos, I've gone into the history of how that stuff comes about. But let me clarify some myths that you may have, okay? But I won't tell you why on this video, just for the sake of brevity. The naloxone in that formulation is inactive and has nothing to do with your precipitated withdrawals, okay? I'm going to say it again. That naloxone, if taken correctly, the strip of Suboxone under your tongue, if taken correctly under your tongue, the naloxone in that formulation is inactive and should only go into your system without going on to your receptors and simply be peed out or sweated out or any other way that fluid leaves your body. Okay, that may come as a major shock to a lot of people, and there's reasons for this. So that being said, everything you hear about, oh, I'm going to use Subitex because it doesn't have the naloxone and I can take it earlier. Last time I took Suboxone, I got sick as a dog. I can't take Suboxone. Or, I have to wait this many hours before I start this medication. Or, the naloxone is going to do the blocking for me, so what's the deal with the Subitex? All of this is nonsense. That's not how the medication works. That's not how the pharmacology works, and these have to do with competing molecules, pharmacokinetics, pharmacodynamics, okay? Whether you start off on Suboxone or you start off on Subitex, which doesn't have the naloxone, doesn't matter how early you start the medication. What does matter in how you start the medication is, although it is dependent on time, we don't know how long, as each person is going to be a little bit different, and the fact that there are so many different substances in there which are synthetic, and the fentanyl and new more synthetic fentanyls and so on. So although the variable of time matters of when you start this medication, that's not how it needs to be assessed, and we don't have a handle on that. We do have a test and a handle, and it's called Clinical Opiate Withdrawal Scale. It evaluates a whole bunch of signs and symptoms, partly, not a whole bunch, about, it takes about 3 minutes to do the test, and it's usually done by a clinician. And what it looks for is it gives you a number, and if that number is correct, it means that you have enough opiates out of your system so that it is safe for you to go ahead and start, whether it's the Subitex or the Suboxone, because both of them, the active ingredient is buprenorphine. Forget the naloxone, and I won't go over it now. I've gone over it in many other videos, okay? So that induction, obviously, as I said, does take time. And nowadays, a lot of people do this at home, even though it's meant to be done by the clinician to avoid precipitated withdrawal. But you need a good explanation. Forget about time. Okay, unless if you plan to wait a week, in which case you may potentially relapse. Forget about time as a factor. It's been 12 hours, I can start it. Forget about the naloxone. You need to know a couple of simple things. Buprenorphine is the active product, no matter which brand you go to. And that product has a much stronger binding to the receptors for opiates than whatever opiate you usually have on board most of the time. And it's going to race to that site, and if it gets there too early with too many sites filled with your opiate of choice, let's say heroin, it's going to kick a whole bunch out and attach to the receptor, and you are going to go into withdrawal. I won't explain why that is since they're both opiates, because I'm really focusing on something else here. And so even if you go home, you need to understand the clinical opiate withdrawal scale. Hopefully your clinician can sort of guide you towards how you're going to get started. And this is a very critical time, because so many times so many people misunderstand and they start the medication too early, get sick, and they get spooked. Okay, within that same concept, and we're still on number 3, is the question of which brand do I go with. And I think at this point they're all indicated for induction, and many clinicians are still concerned and worried about Subitex. Can be people can abuse Subitex versus they can't abuse Suboxone. That's up to the clinician, all right? My goal here is to get you on it, and I know if you're kind of goofing off or things aren't right, and I'm going to know in short order. I just want to get you on this medication. If you've used Subitex before, I'm going to get you on Subitex. If it's Suboxone, I'll do Suboxone, Bunavail, whatever it is. I'm comfortable with all of them, and it doesn't matter. Most people that start this stuff, they already know because they may have tried it before. But for those that are uninitiated and it's their first time, I recommend going with Suboxone, both the fact that it has indications, it's easy to use, a lot of experience with it, and so I choose Suboxone. And the way this initial titration is done, okay, is, that first day that you start this medication, you got to be in touch with the doctor. You can't take a couple milligrams and find a little bit of relief and then you go about and wait till the next day. There should be a plan or a program over the next 24 to 48 hours, whatever it is, and it's usually done much quicker than that, is to titrate you up as quickly as possible, and this gives a buffer of safety. A, if you use, you're not going to get high. B, you're going to find relief in terms of cravings and withdrawal. So that's the next thing, right? The induction and the brand use. And your physician should be guiding you through all of that. Now, let's say on the first day I get John or Joe up to 12 or 14 milligrams or 16 milligrams, okay? And here's where the next 1, 2, 3, 4 days are very important. Again, your clinician should initially have a mechanism to follow you very closely in those first few days. Why? You could be taking it wrong. You know, I've seen people take the whole thing at once. You could be underdosing. You could be taking too much. You've got the patient started on buprenorphine products, and it's important not to blow it. I just almost blew it recently on a patient, right? Where I try to, my personal practice and my different programs and everything that we have, or organizations, we have quite a few people that engage with us on a weekly basis, right? And I myself, I'm a little bit less clinically involved nowadays, although I try to be at the initiation and outset of care. And we're quite busy, so there's a dependence on other team members to make sure we try to deliver the same care and service to everybody, and in the same way that I always did it when I was completely by myself. What does that mean? In those first few days, you will be coming into contact with us very regularly, and we will adjust and take care of what needs to be taken care of. And a patient got started, and I believe that day, in their case, they went up to 8 milligrams, 4 in the morning, 4 in the afternoon, or whatever, and the instruction was given for the patient to follow up in the next few days. Somehow that was dropped, and I had seen the patient myself because I really try to see a certain group of patients initially because I enjoy it. Our PA Alexis is fantastic, and me and her discuss all patients all the time. And somehow this got dropped, and with my schedule, it wasn't passed on to me, and I couldn't remember. And a week and a half went by, and the guy was craving because he wasn't appropriately titrated up. The issue was addressed, and everything is fine, but that's a dangerous time. So all clinicians should be following you very closely in the first few days. If you're getting a script being sent home and told that you'll be seen next month, a monkey could do that for you. That's not what you want. You need all the emotional, cognitive, clinical support that you can get initially. So in the first few days, that dose needs to be brought up to the right milligrams. And I'm going to give you an example of what I really mean by that. Let's say I do the induction and on Saturday, and maybe I'm doing it by phone, and we get you started. You're at the appropriate clinical opiates withdrawal scale Saturday morning. We get you started. We start with that small dose, get you up to 4 milligrams, 6 milligrams, whatever, 8 milligrams, and that's by the end of the day, and you go to sleep. Well, the next day, I gotta really think about what's going to happen with your cravings and withdrawals over the next 24 hours, and how are we going to separate or dose that total of 8 milligrams of the previous day. By the way, you can break the doses up. And do we need to go up? And that's the clinician's job to figure that out. During this whole time, let's go back to number 1, 2, and 3. You should not be aiming for being on the lowest dose possible. You should be aiming for being comfortable. And the clinician should be doing this for you. It is at this time, after a few days, when that sweet spot has been nailed in regards to your dose of buprenorphine, that the clinician should go back now and start to assess certain issues, right? Insomnia. Because, this group of patients comes with a host of many mental health and behavioral issues that do need to be addressed. And that's when you go and start to look for real anxiety, for real panic attacks, for real insomnia. And the clinician should now be adjusting and making decisions about how, when, and which additional medication he wants to sprinkle on, okay? In that initial phase, you really don't need much else. People will tell you, I need this muscle relaxer, gabapentin, which I would advise, hey, let's taper you off the gabapentin. You don't need much, but after 2-3 days, everything should be adjusted as far as the Suboxone, and now the clinician should add to sprinkle on some additional medication for as needed for things like sleep and so forth, and start to address issues over the next week or maybe 2 weeks in terms of social issues, right? Family issues, the need for therapy, how much therapy, social issues, legal issues. And I think that's the clinician's job, because the goal is because now that patient is sort of waking up, and it's gonna be for a moment, it depends on who you are, but for some it might be a honeymoon period. For some it might be too painful to be awake without the warm blanket of the opiates. And this is a critical time for different users or those suffering from addiction, that they may have different needs, okay? All of a sudden, it's just too painful to deal with all of those issues that you had that sort of led you into addiction in the first place, for example. Okay, maybe childhood abuse, maybe certain types of trauma that you had. I hope that gave you a little bit of information. I hope that was expanded your knowledge base, whether you're the patient, loved one, friend, or a clinician. Please go ahead, press the like and subscribe button if you enjoyed that. Leave your comments below. I really want to see if I can generate a discussion on this topic for those suffering out there, which I think of as the new phenotypic substance abuse patient as an outcome of shifts in our culture and society. This is Dr. Banimat. Have a great night. I will see you soon.